Dada,
Yes, Mama.
what are common fractures?
Okay, so when it comes to common fractures, there's a lot. There's like 15 of different types, right? The way that they're classified. But I'll discuss three. Okay, so the first one is a comminuted fracture. A comminuted fracture is when the bone fragments into at least three pieces, usually caused by crush injuries. And this is a very tough fracture to like fix because this requires external fixation, where you have pins. You have internal fixation, or where you have pins that are going inside, outside the skin, and it takes a long time for them to heal. But that's a comminuted fracture. Think of community is composed of a lot of people, so comminuted fracture, a lot of fragments, at least three fragments in a comminuted fracture. The other type of fracture is known as a green stick fracture. This usually happens to children, and it's usually suspected or treated as potential for child abuse. And this is because if you think about a branch of a tree, right, that's fully matured like an adult, it's the bones are ossified, meaning the tree branch is dry, it's hard now. When you break it, it snaps right through. That's what happens to adults when we put pressure in our bones break. But a child, since their bones are not ossified yet, it's still green. If you think about a branch that is from a live tree, it's green. When you break it, it only partially fragments. It doesn't break all the way. And so that is treated as potential child abuse simply because it takes a lot for us to break a child's bone. It's like by grabbing them very aggressively or by forcefully breaking or bending the arm, which will usually cause a green stick fracture. And if you think about a branch that you remove, when you break it, it doesn't go all the way through. So that's a green stick fracture. Another type of fracture is a compound fracture. This is a bone that breaks through the actual skin. And this causes a lot of potential issues because of the introduction of bacteria, pathogens. And so compound fractures can always lead to infections such as osteomyelitis. Keep in mind that when it comes to fractures, depending on the severity of the fracture, you may have to perform something called an ORIF, open reduction. When they open your skin, they reduce or they put the bones back together, and then they do internal fixation, which means underneath the skin they put pins and rods and screws to fixate, to immobilize the fracture. Then they sew you up, and then they put a cast if that's what it's going to be, if that's what's going to be needed. So open reduction, internal fixation is important for you guys to know. I want to briefly discuss vertebral fractures because I want you guys to understand wherever the fracture occurs in the vertebrae, the level of the fracture where it occurs, there will be a deficit from that point and below. So if you have like an L1 fracture, right, the first lumbar vertebrae, well, then you're going to have a deficit, meaning you're going to have either an absence of sensation, an absence of movement, or anything in between. It could be it could be muscle spasms. It could be just a lot of pain. It just depends on the severity of the fracture. Or if you have a fracture to let, oh, and then by the way, an L1 fracture, that's lumbar fracture, then you're going to have potential paralysis from that level and below. And the same thing happens when you have a fracture, let's say your thoracic or your cervical vertebrae. You have to know where those are located because the deficit will occur from the point of fracture or injury and below, the potential deficit. And like I mentioned before, it can range from anything as just pain to spasticity to flaccidity to complete paralysis, and it just depends on where in the vertebral column or the vertebrae the fracture occurs. So in a nutshell, guys, that is your fractures. But I do want to include one other thing. When you have fractures to extremities, we place casts on that extremity. So you have to look out for compartment syndrome. So before I discuss that, when you apply a cast on a patient, you have plaster casts and you have fiberglass casts. Fiberglass dries a lot faster. You should never use a heated blow dryer to speed up the drying, but you can use a blow dryer in a cool setting after the cast has been placed, to kind of like alleviate the pruritus, the itchiness. And it's weird, but that's what the book discusses, and it's something that NCLEX also knows. Keep in mind that any patient that has a cast on, you have to do a neurovascular assessment. Circulation, motion, sensation of that extremity of the toes, wherever the cast is at, because the patient is at high risk for developing compartment syndrome. And compartment syndrome is when that extremity begins to swell, inflame, but the cast limits its expansion. That compresses the tissues, it compresses the blood vessels, and so the hand will not receive adequate perfusion. So you may develop something called Volkmann's contracture, which is a permanent stiffening of the muscles because they atrophy due to the lack of blood flow. Patients that potentially develop compartment syndrome, you have to remove the cast with a it looks like a pizza cutter, but it vibrates. It doesn't oscillate, so it won't cut the skin. It's pretty safe. I used to have a cast because of this injury that I have right here. So you have to educate the patient that we're going to remove it if they have compartment syndrome, and they may have to perform a fasciotomy where they cut into the tissue down to the fascia. It opens the skin and it allows the perfusion to improve, and that saves the actual muscle from shriveling and atrophying away. So in a nutshell, that's what you guys got to know about fractures.